My topic of presentation today is central lymph node mapping in endometrial cancer. And I believe that central lymph node mapping in endometrial cancer defines the optimum staging, which is neither maximum nor minimum. So why do I believe that, and what data we have, and a short video presentation of the same will go through in my presentation. So every one of us knows that what is a central lymph node is the first draining lymph node that comes from the primary tumor, and there may be second tier and third tier lymph nodes. So we are basically interested in finding, mapping, and properly ultra staging the first lymph node, which is draining from the primary tumor. So this has already been established in breast malignant melanomas to detect occult nodal metastasis in previously, and now since 2014 it has been widely being practiced all over the world for gynecological malignancies like endometrial, cervical, and vulval malignancies. So the foundation stone was laid by the Aztec and the Italian trial, where they concluded that there was no therapeutic role or survival benefit of doing a lymph node dissection in low-risk endometrial cancer. There were many arguments to this trial, but these are two landmark trials which founded the, which gave us the thought that should we be doing complete lymphadenectomy in all patients of endometrial cancer, specifically the low-risk ones. Then in 2019 came out a paper. It was a retrospective analysis of the Franco-Gyne database, the France database of gynecological cancers, where Bugrera et al. They defined the role of it in intermediate risk endometrial cancer, and they concluded there is no role of complete lymphadenectomy even in the intermediate risk group. And the role of central lymph node biopsy in the intermediate risk group was emphasized in this trial. Zhang et al. Looked into the SEER database, and they concluded that complete lymph node dissection has no survival benefit in stage 1A cancer of any grade of endometrial cancer, even in the high risk grades. And there are a lot of retrospective trials, and the European trial, which is called the SHRDC trial for high risk endometrial cancer, that has been published, which has validated the role of central lymph node biopsy even in the high risk group. There is a grade 3 endometrioid and the non-endometrioid endometrial cancers. So this was included in 2014 in the NCCN guidelines for low risk endometrial cancer, and the algorithm that was followed was the MSKCC algorithm for central lymph node biopsy. So what are the advantages? There are definite advantages to central lymph node biopsy. There is low rates of lymphocyst formation, low rates of nagging lymphedema in the patients, low chances of rather injuring the vessels or the nerves in the pelvis, low risk of VTE, venous thromboembolism, low risk of infection, and definitely low operative time. But the lymph node metastasis detection rate is also 2 times higher than in a normal lymphadenectomy. Why? Because the pathologist has lesser lymph nodes to examine, so they can concentrate. There is ultra-staging of nodes. There is extensive histological examination of the 1 or 2 nodes that are harvested, which are sectioned at 2 millimeter sections, and the aberrant pathway. So if we are, suppose, as per the risk stratification, if we are doing pelvic lymph node dissection only for a patient along with hysterectomy and BSO for a patient of intermediate risk endometrial cancer, but the actually draining primary lymph node is in the common iliac or the paraaortic region, then we will miss the primary lymph node, the central lymph node, which is draining into the paraaortic area, and we will be dealing only with the pelvic lymph nodes. So a metastasis may be missed. So it picks up the aberrant pathways and the unusual locations of the first draining lymph nodes. What are the types of dyes used? A lot of dyes has been used. So older dyes were the active dyes, methylene blue, patent blue, indigo carmine. Then came the radionuclide dyes, which is technetium-99, sulfur nanocolloid, and along with a gamma probe. But believe me, I had started doing central lymph node using blue dye plus radionucleotide dye. This has a huge logistic issue. The dye should be available in your department of nuclear medicine. Sometimes the dye you have put up the patient for surgery, the dye is not available, so you cancel the surgery. Then the patient has to undergo a scan the day before. Then there are two protocols of giving the dye, and you are completely dependent on the nuclear medicine department when to start your surgery and when to harvest your nodes. So that really hampers the surgical flow in a surgeon's day of work. The carbon nanoparticle is a newer one, but the most promising one has been the indocyanine green dye and the near infrared imaging, where we use light at 700 to 900 nanometer. So that is the most promising and the most widely used modality of the dye for sentinel lymph node biopsy in the present world. And there is a trial, which is a film trial, which was a non-inferiority randomized trial, where they had shown that the ICG detection rate was about 97% compared to 48% for methylene blue. So there are other trials like FIRES trial, which also establish the superiority of this dye for detecting sentinel lymph nodes, and this is now the most commonly used dye. Yeah. So route of injection has been also debated, and there has been various route that was used previously. The most commonly used is the cervical injection. Then there was hysteroscopic peritumoral injection, and then the subserosal injection, where we used to inject the dye into the serosa near the fundus or the cornu, so that the paraotic nodes can also be mapped for it, for the endometrial cancer from the uterine body. But over time, there has been a lot of retrospective trials which have shown that cervical injection is the simpler, faster, and the most effective way of mapping sentinel lymph node biopsy. And even the Sloan-Kettering protocol follows the cervical injection, which is included in the NCCN guidelines. So this is the sentinel lymph node algorithm that we follow at our institute. It comes from Sloan-Kettering by Dr. Abu Rustam and group. And we will come to it during our video presentation also. So we'll skip this one and go ahead. Then histopathology in our hospital is also done as per the MSKCC algorithm, where a sentinel lymph node is sectioned at 50 micrometer apart. They are initially stained with H&E stain. If they're positive, we stop it. If they're negative, then we do ultra staging, and again go ahead with IHCs like cytokeratin. So the mets can be micromets, which are less than more than 0.2 to 2 millimeter, isolated tumor cell, which are less than 0.2 millimeter. And there can be macromets, which are more than 2 millimeters. So these are the three types of mets we generally get in a pathological report of sentinel lymph node biopsy. I will come to the significance of those later on. So coming to the video presentation for this, so we use the Firefly technique, which is integrated with the robot. You can there are integrated systems of laparoscopy also where you can do it. So this is the initial lithotomy position of the patient. The cervix is exposed, and the dye we use is indocyanine green, which comes in a vial of powder, 25 mg in the whole vial. We dilute it with 10 ml, with 5 ml of sterile water first, and then we dilute it in another 10 ml, leading to 2.5 milligram per ml of solution. The dye is injected at 3 and 9 o'clock position in the cervix. The injection is 1 millimeter 1 ml is injected superficially. That means only the tip of the needle goes in, and you inject 1 ml, and then deep, which is like 1 to 2 centimeter into the cervical stroma on the side, and you inject another ml. So it is 2 ml per side. So after the injection is done, the patient is prepped, and we start the minimally invasive surgery. So the first step of any surgery is peritoneal evaluation. So if we find a picture like this, where there is a serosal disease or there is ascites or tumor deposits, we abandon sentinel lymph node biopsy straight away and go ahead with open complete surgery. Then if we have any suspicious enlarged node, it must be removed regardless of the mapping, because this may be enlarged tumor loaded nodes which whose lymphatics may have been blocked. So we should remove the enlarged nodes also. This is the view of the dye, and this is the most common pathway through which the dye travels. This is the lymphatic channel coming via the parametrium, crossing the obliterated umbilical artery, and draining to the external iliac, internal iliac, or the obturator node. The most common is the external iliac group of nodes. So this channel, the identification of this is will cross the obliterated umbilical. The less common pathway showed here in green color is the channel where it doesn't cross the obliterated umbilical, rather it follows the mesoureter. This is the ureter. It follows the mesoureter and drains into the paraortic or the presacral group of nodes. So these are the group of nodes we may miss if we do only PLND and not SLND. So this is opening of the retroperitoneum. Every one of us know about it. This is the obliterated umbilical, and here we can see that this channel is crossing the obliterated umbilical. There's the internal iliac and draining to this external iliac group of nodes. The brilliant green is seen in the near infrared imaging. So this we should check repeatedly and confirm that this is the first draining lymph node. Remember, the first node that you are seeing always may not be the first node actually which it is draining to. It may be a secondary central lymph node. So while we were dissecting these, we found that there may be other lymph nodes which can be down in the obturator fossa. So we started dissecting the obturator fossa, and when we went in and see, this is the central lymph node, and that was the secondary central lymph node. So you dissect out the central lymph node. So central lymph node biopsy has its own learning curve. So you need to do a good number of cases. I will come to that later on, what actual number of cases before you say that, yes, I am doing central lymph node properly. It has its own learning curve. So this technology is available both robotic and laparoscopically. So this is the example of a single lymph channel bifurcating into two lymph nodes. So both of them are primary central lymph nodes. None of them are secondary. So we should harvest both of them. So how do we use the near infrared imaging? It's very simple. In the robotic platform, it happens with the toggle of pedal. You press the camera pedal and clutch the finger bows, and you change to near infrared imaging and back to normal imaging. We generally use a spoon forceps or the bag to take it out. So I will come to some examples of atypical central lymph node locations. This is one, you can see this is the uterine artery, this is the internal iliac, and this is the ureter. So this is an example where it is not crossing the obliterated umbilical and is following the mesoureter and going up to a subaortic or presacral group of lymph nodes. So if I had done only PLND for this patient, I would have definitely not removed this node, whereas this is the primary node which can be having the main metastases here. So be careful while doing it. It has its own learning curve, and you have to take time before you say, yes, I'm a master of it. It needs a certain amount of time, a certain number of cases which has been defined already. So if there is no mapping in any one of the pelvis, you cannot find any mapping, then the MSKCC protocol was to perform a site-specific lymph node dissection. But in our case, what we have started doing after a European trial was to re-inject the dye, another 1 ml of the dye in the same side of the cervix where there has been no mapping of the lymph node. And this has led to a much better detection rate and yield of central lymph nodes. I will come to that. I will show you our data, what we have. So this is our data from Tata Medical Center, Kolkata. We have basically run this as a prospective validation study where we have validated the Sloan Kettering protocol. We have done it in 250 patients. We have already analyzed this data, and this is up for publication. So these 250 patients included all risk categories of endometrial cancer, where we have done pelvic or paraortic lymphadenectomy over and above central lymphadenectomy in all patients to validate the sensitivity, specificity, and the negative prediction, negative prediction value of central lymph node. So our detection rate was in these 250 patients, 50 patients were high risk patients, and the 200 patients were in the low risk or the intermediate risk, but all of them has central lymph nodes done. So our detection rate was 98.6%, and the bilateral detection rate was about 88.1%, which is almost similar to the Centaur trial, which you can find out in NET, where they have defined the detection rates very nicely. specificity was 100%, sensitivity was 96%, which is similar to the landmark FIRES trial, and the negative predictive value was 98%, which is a very good standard. And 12.8% of our patients had occult metastases. External iliac lymph node was the most common lymph node where the sentinel lymph node was mapped. And we had only one patient with false negative sentinel lymph node. And that was in the early part of our learning curve. So sentinel lymph node has a steep learning curve, and it has been defined by various studies that you need to do at least 25 to 40 cases of sentinel lymph node biopsy before you attain the learning curve, and you can say that yes, I'm doing it properly in my patients, and we can replace this for complete lymphadenectomy in at least low risk patients. So coming to re-injection of dye, the previously stated algorithm was, if you do not find a sentinel lymph node in one of the hemipelvis, do a complete lymphadenectomy in that side. But this European trial, which is the SHREC trial, where they had included patients of the high risk group, what they have done is they have re-injected the dye. So we included that in our protocol. So in 21 patients, we had no sentinel lymph node mapping after the primary injection of the dye. So we re-injected them on the specific side where the dye, there was no mapping. So after re-injection of another 1 ml of dye, 19 of them had successful mapping and 2 did not, even after injection of the dye. And so we can definitely say that re-injection increases to detection rate. So of these 21 patients who were destined to have a complete lymphadenectomy of that side, we saved 19 patients by successfully mapping, and only 2 patients who didn't have any sentinel lymph node mapping, even after re-injection of the dye, we had to do a complete lymphadenectomy in that side. So the questions that need answers for sentinel lymph node biopsy, even though it's a established protocol nowadays for low and intermediate risk, is what is the acceptable false negative rate? What does the learning curve of this technique involve? That is very, very important. Do 2 cases and can't say, okay, from now on, all my patients will have sentinel lymph node, I will not do complete pelvic lymphadenectomy. You should not jump to that conclusion so early. If the sentinel lymph node is negative, is it oncologically safe to abandon lymphadenectomy? So because all this trial till now has focused on sensitivity, specificity, and negative predictive value, detection rates, and everything. But we are awaiting the oncological outcome of these patients in who had only sentinel lymph node biopsy as a measure for staging in endometrial cancer, whether they had nodal recurrences or not. We are awaiting those results yet. And what is the role of micromates and isolated tumor cells? Micromate upstages your patients, but isolated tumor cell does not. So do they lead to more pelvic recurrences? Should we start giving adjuvant treatment for these patients who are having isolated tumor cell or micrometastasis? These are the questions that definitely need answers. And the future is correlation of sentinel lymph node biopsy with molecular classification. Just to inform you all that all of our patients at Tata Medical Center have undergoing surgery for endometrial malignancy. In the specimen that goes to pathology, MMR genes and P53 is routinely done. We have recently started doing Pol E also. So the only correlation that we could found that the only patient in whom there was false negative sentinel lymph node, only one patient we had, that patient was MMR deficient. I do not know. It's very early to comment that whether it has any correlation, but this will be an interesting point to look into in our future trials. So to conclude, sentinel lymph node algorithm is a standard of care in many centers for early gynecological cancers. Even some centers like Sloan Kettering, MD Anderson, and some European centers have given away to sentinel lymph node biopsy instead of doing a complete lymphadenectomy, even for high-grade endometrial cancer in early stages. So I will recommend that if you have not yet incorporated sentinel lymph node mapping in your gynecology practice, I encourage you to do and consider it doing sentinel lymph node biopsy for this patient, because it gives a huge advantage to these patients They have much less morbidities to encounter, and you have much less operative time also. The only limitation is the cost of the near infrared imaging armamentarium or the instrumentation. So if you do not have that, you can basically start with simple methylene blue. That will help you, build up your learning curve also. So when you get the armamentarium or the instrumentation at hand, then you can start doing it with ICG. The dye itself is very, very less costly in India. It costs about 900 to 1,000 rupees for the injection, because it is produced in India by a company. We don't have to import it. But yes, it comes incorporated with the robot. It comes incorporated with some, most of the advanced laparoscopy stacks nowadays, like Carl Storz, Stryker, everyone have incorporated this. But these stacks definitely cost much more than a normal laparoscopy stack. So this cost of armamentarium is definitely a limitation towards it. And if you do not have that, start doing it using simple methylene blue, and that will help you develop your learning curve for central lymph node biopsy in your practice. That's all from my side. Thank you for again the organizing committee for giving me the chance to present on this topic.